Hello, welcome to this lecture. My name is Glenn Nidlow. I'm a prosthodontist from Perth in Western Australia, and I'm going to be talking to you about treatment of mandibular edentulism and the terminal dentition. So when we talk about edentulism, usually we're getting edentulism from caries or periodontal disease. There is a cumulative effect. So the percentage of edentulous people increases with age. So the numbers are actually quite large in the first world countries. Maybe 58% or so of over 75-year-olds are edentulous. This rate of edentulism is dropping by around about 1% for industrialised countries, but the lifespan has risen. So this over 65-year-old demographic is actually rising in all countries, and that effect will actually outpace the decline in edentulism. So there are denture patients, obviously, to treat edentulism, and maladaptive denture patients have got little correlation with the quality of the dentures, and there's a strong psychosocial component. There's obviously a progressive degeneration of supporting tissues and neuromuscular control, and so an adaptive denture patient, someone who's happy with their dentures, may become maladaptive with time with this degeneration. That affects their psychological health. It changes their food selection. They tend to go for a lower nutrient content food. There's more processed foods, more fats and cholesterol, and so this has, quite detrimental effects on their overall health. We know that if we treat people with either fixed or removable implant prostheses, then we can improve their oral health related quality of life. That can lead to a higher nutritional state, and you get improvements in blood parameters and anthropometric measures after treating people with an implant type of restoration. So there's various strategies for treatment of the edentulous jaw. You can go with complete dentures, and there are many people in this world that have complete dentures. You can go to implant overdentures of various numbers and types, and you can go with implant detachable prostheses. Then there is also the fixed prosthesis as well. So when we're looking at dentures, if you ask a whole bunch of prosthodontists what their favourite type of edentulous patient treatment is, it'll be a complete maxillary denture, and it'll be a fixed prosthesis in the lower jaw. And that gives you the least maintenance, and we find that you have the least problems over a period of time because you've got some cushioning effect of the maxillary denture. People that come to me and want implants in both jaws, I generally organise for them to have a good complete maxillary denture and a fixed bridge in the lower jaw, and probably 75% of people are happy with that. So it's something that is a good treatment strategy. Obviously, complete dentures allow us to do all sorts of things with facial support. And even when there's very little ridges, you can do an awful lot of things. Whether or not you decide that this is cosmetic or not is up to you, but you can certainly do quite a lot of lip support, facial support with the use of the flanges of the dentures. Which brings me to overdentures. So overdentures are defined as any removable dental prosthesis that covers and rests on one or more remaining natural teeth, either the roots of natural teeth or dental implants, and it covers and it's supported, partially supported by the natural tooth roots and or dental implants. So there's a lot of different ways of doing an overdenture for the mandible. You can have a 2-implant overdenture that might be splintered or it might be separated, and so this has been quite a successful type of treatment procedure. So in 2002 there was this McGill consensus statement which said there's now overwhelming evidence that a 2-implant overdenture should become the first choice of treatment for the edentulous mandible. I don't have a big problem with that statement. I do have a problem with, if you read the actual reference where it says the first choice standard of care. That implies that anything else is not the standard of care, and I don't quite believe in that. I think that prosthodontic treatment is really related to what that patient wants. So a lot of complete denture wearers, they adapt and they cope very well with their dentures. Some of them suffer substantially, and they might develop some chronic dysfunction, pain, and like I said before, low self-esteem and reduced oral health related quality of life. I think prosthodontic treatment really should provide safe solution that's least invasive, least costly and least complex to meet the reasonable needs and expectations of that particular patient. And so we need to target what we're doing to tailor the treatment towards the patient themselves. And so we want to aim for a level of mechanical stability, biological stability, longevity, and the least maintenance possible for those patients. Now, if we look at the literature, there's a lot of literature on overdentures. It's quite clear that overdenture complications are much higher than with fixed prostheses. You get more peri-implant mucosal problems, you get more mechanical problems, which is related to the attachment mechanisms of overdentures. We do, however, have less phonetic problems, particularly when we go from an existing denture to an overdenture, because the contour is obviously not going to change very much. If we look at attachments and splinting, there is a lot of different ways of doing overdentures. You can range from a single implant overdenture to multiple implant overdentures, splinted or unsplinted, with various types of attachments there. If we look at splinting versus unsplinting, you've got various types of references that are available, and most of them using finite element analysis or survival rates of overdentures show no real difference as to whether the implants are splinted or not splinted. Likewise, prosthetic complications, there's no great difference between the two. Nevertheless, overdentures remain something that is relatively inexpensive. It's a removable prosthesis, so some patients prefer that. They find it easier to clean. It's certainly simple. It provides good stabilisation for the denture. It's applicable to an existing denture, so you don't necessarily have to change the denture, or you don't have to change drastically what the patient is already used to. And like I said before, there's a large patient potential there. When it comes to placing implants for overdentures, there's been quite a lot of studies on immediate loading of dentures, of overdenture implants, and all of those show very good success rates. And there's been some systematic reviews as well to show good success rates over a reasonable period of time. A lot of the systematic review types of references are relatively short term, but now we're getting longer term studies that show good success rate with immediate loading. Which leads me to probably one of the most simple ways of improving overdenture as far as their function goes and satisfaction. So this is a study that we've already published 1 year and 3 year results, and I'll talk to you now about a 10-year results of the single implant overdenture for the mandible. The study went something like this. It was a prospective study of already maladaptive complete denture patients. So all of these patients were unhappy with their lower denture. Involved single stage surgery, immediate loading. Now this was started some 15 years ago. And so what we were doing was we were comparing the machined or the turned surface implant compared to an oxidized surface or the tyenite surface implant. And we're looking at obviously implant success, function, patient satisfaction. The patients had to be completely edentulous. This is not an approach that's applicable for, say, where the maxilla has been already restored or is dentate, for instance. They had to have enough bone for at least a 10mm implant, and the mandible had to be edentulous for at least 12 months before being included in this particular study. The exclusion criteria is the normal exclusion criteria for most research protocols. In other words, there's no disorder or augmentation to the implant area. We didn't have any psychiatric, drug, alcohol issues, usual surgical exclusion criteria, and logistic reasons that might have prevented follow-up for these patients. And what we did was we did single-stage surgery with minimal flap. We tried to get bicortical stabilisation if possible. We needed to have a high implant stability, so the insertion torque had to be above 35 Newton centimetres and a resonance frequency analysis of at least 60. And they had to have satisfactory existing dentures. So we didn't make perfect dentures with balanced articulation and stippling and tinting and all that sort of thing. They just had to have reasonably good existing dentures. So we were, as I said before, we were comparing the machined surface implant versus the oxidized surface implant, and we used what was available at the time, which was the 3.5mm ball attachment. What we found was that there were 3 implants in our cohort that didn't get the required stability. So we went with a 2-stage procedure, and they've all been successful at 10 years down the track. what we did with the first 15 patients was we immediately included the attachment into their denture. We're using self-cure acrylic. The problem with that was not so much with a problem with implant stability or implant success, purely because you didn't allow the tissues to expand, and so you had swollen tissues that the patient had problems putting the denture on with. And so they had this inability to seat, which caused them discomfort. So we changed our protocol and relieved the denture, like on the left-hand side, and then placed a soft lining material for 6 weeks while we got soft tissue healing. And then we went ahead and did a glab reline at 6 weeks. And it's important to note here that we're not relying solely on the implant for stability of the denture. It still has to have, you know, adequate extension and fit, because it's basically a soft tissue supported denture that is retained by the implant attachment. So if we follow the soft tissue and the look of this procedure for the 10 years, we can see that, you know, we get some initial tissue remodelling, and then we've got a stable implant, you know, 10 years down the track. And the results here was interesting. So if we look at the machined implants, we had placed 8 implants and we had 3 failures within 8 weeks, which gave us an unacceptable success rate in our terms, and so we discontinued the machined implants from the study. I think this is a fairly extreme type of loading that's placed onto immediately placed implants, and so we discontinued that. We could no longer support doing that. Now the remaining 5 implants though that did machined implants were fine at the 10-year mark, so it's interesting. If we look at the tyenide implants, the oxidised surface implants, we've had no failures at all over a 10-year period, which is quite remarkable considering the loading that's placed on these implants at a short period of time. Now we've had some withdrawals from the study, of course. We've had a couple of deaths where they were unrelated to the implants, and you know, we're dealing with an elderly population here. Now part of the reasoning for, you know, the possible reasons for the machined implants having a high failure rate is that there is a definite dip in implant stability in the early period of healing, and whereas we didn't find that dip in resonance frequency values with the tyenide implants. If we also look at bone loss, there was a statistically different level of bone loss, statistically more significant with the machined implants than there were with the tyenide implants over the whole time of the study so far. Plaque control, as you can expect, ranged from very good to, you know, pretty ordinary, and we're dealing with a patient group that often have reduced manual dexterity. They may be relying on nursing help, for instance, if they're institutionalised, and so it varies quite a bit. There was some unusual complications. There was some tissue shrinkage. There was habitual tissue trauma with someone pulling their lip over the top of the attachment and causing damage to the tissues. And there was some mucosal enlargement and also denture fractures. If we looked at satisfaction in this study. And so what we did was a visual analogue scale questionnaire, and we compared, they placed a line on placed a cross through a 10 centimetre line as to whether they were happy on a range of questions, you know, their ability to chew, social, speaking, fit, etc., etc. And so when we analyse this, you can see quite a dramatic change from the pre-treatment area, where we're looking at sort of 30 or 40% for most parameters, up to the 90%, which maintained its satisfaction rating over the 10-year period. So we had very satisfied patients, considering that they were maladaptive and very unsatisfied to start off with. The other thing that's quite interesting and unique to single implant overdentures is the prosthetic maintenance. And so you will all know when you're doing a 2-implant overdenture that you get a lot of retentive cap problems. They tend to wear out, they tend to distort, and so often in certain systems you may be replacing retentive caps every 3 to 6 months or so. Well, with this particular one, we had no retentive cap problems at all over that period of time, We had the usual relines that we would have. You would expect to see relines every 3 to 5 years or so. And we had new dentures made, again, as expected. Not very many unscheduled visits at all. And three denture fractures, and that was when we were in the first 15 where we were putting the attachment in with the cold cure acrylic. So since we went to a lab reline, we had no denture fractures. So really, this is a very applicable treatment modality, particularly for people that have got decreased manual skill and visual acuity. And so it's a good way of improving things, particularly for some of our elderly patients. And so this happens to be the close-up of a patient who's, she's 91 now, she's in the study, and she's got fairly advanced dementia, unfortunately, but she's coping very well and she's able to eat, and nursing staff can keep that very clean. So I would urge you to have a look at this particular modality. Now moving on from the edentulous patients to what is a much, much bigger cohort, of which we'll never ever get good statistics on as to what percentage of the population has a downhill dentition or a terminal dentition, but it's much, much bigger than the edentulous population. So there's a lot of patients that need our care that maybe don't know that they need our care quite yet. There's also a little cohort such as this 11-year-old who's got oligodontia or virtual anodontia. He's got ectodermal dysplasia. There's a certain percentage of the population, of which I see quite a few, who have no teeth and no possibility of any teeth. And so usually at around about 11, where psychologically it becomes important for self-esteem, we do an all-on-4 type of treatment in the mandible and a complete denture in the maxilla. They've already usually had a complete denture, and this improves the quality of life no end for these unfortunate patients. But getting back to the more normal sort of situation, a terminal dentition, what is that? It's a residual dentition that's considered by clinical parameters or maybe economic rationalism to be unable to be restored for a reasonable prognosis. So we can either do two things. We can wait until it self-destructs, or we can intervene earlier, maybe we retain some teeth. We might help to maintain facial form, improve their speech, and also we can limit bone resorption. So what do patients want? Well, patients want to look like these guys. That can be difficult sometimes when you're looking at that particular patient. They don't look anything like these people, but that's what they want. Can we go from a terminal dentition to an implant rehabilitation? Of course we can, and there's plenty of studies and cases and all that sort of stuff on the lecture circuit that shows you, you can place a certain number of implants depending on your preferences, and you can provide that person with a fixed dentition within a day or two. And that's a fairly standard protocol these days, and we can improve terminal dentition patients very easily. What are patients actually satisfied with? Well, patients can be satisfied with a variety of different treatments. As I mentioned, we can go from single implants to full arch fixed bridges with ceramic bridges and anything in between. If we're looking at currently edentulous patients though, they're generally satisfied with a 1 or 2 implant mandibular overdenture and a complete maxillary denture. If we look at the literature and we compare it with fixed mandibular prosthesis, it's fairly equivocal. With younger patients, they prefer fixed prosthesis and you get a better function, whereas older patients that already have removable appliances may prefer to have an overdenture. There's no studies on terminal dentition and the various satisfaction with prosthesis. So we don't necessarily know what that cohort of patients would prefer. Generally speaking, in my experience, I would say that if patients are financial, fixed is far more predictable, it has less maintenance long term, and it has a greater level of patient satisfaction. If a patient has their own teeth, they want some teeth at the end of the day. They don't want an appliance that comes in and out. So if we look at the mandible, there's a large history of fixed appliances on in the mandible, and it goes right back to the original Brunner-Mark studies. Immediate loading, we know that we can immediately load the mandible, very predictable when we're placing a fixed prosthesis. And what has that got to do with it? Well, the mandible generally has good quality or more dense bone, and so that allows us to get a high level of stability, and so we can predictably place implants and load them immediately, and we know that that's going to work. How many implants do we need? Do we need this many? Or maybe this many? Either way, we did a study by my mentor, Patrick Henry, back in early 90s, which looked at immediate loading of 4 implants in the mandible. And what that showed was that we had less bone loss around the immediately loaded implants compared to the ones that were left buried, unloaded, and we had high success rates. And so we've got high success rates 20, 25 years down the track. So we know that this is a predictable way of doing things. All on 4 obviously is something that has taken off and is very successful, and so a study that we've been involved with is looking at consecutive patients that have been treated for at least 5 years up to 11 years, and we have a 99.6% success rate using, say, replace implants. And so as long as you're using an implant that has a high level of stability, such as the Noble Biocare implants, then you can be assured that you're going to get a good success rate with this particular modality. And importantly, we have a high level of satisfaction. So how many implants do we actually need? We know that when we're placing the implants, particularly when the cantilever is more important, and most of the force goes onto the distal implant, and the second implant that's closest to it has less force, and then the rest of it is the distribution or the biomechanics goes around the rest of the arch. And so very little actual loading goes on the centre implant. And so patients that have had a 5th implant in the middle, there is more bone loss on that 5th implant. And so that's been shown in studies as well. That there may be some relation there. Maybe it's due to poor plaque control, maybe it's because there's less space between them, maybe it's an unloading type of issue, but either way it's probably unnecessary. So we've seen this also clinically with more bone loss on that central implant. Why don't we place more implants, say posteriorly for instance, and have them cross-arch? Well, there's mandibular deformation. There's corporeal approximation as you open your mouth of sometimes up to 700 or 800 microns. And so that can be enough to cause some problems, stress to the prosthesis, which can result in pain in certain situations, can involve screw fracture, loosening and all this sort of thing. It's due to the cross-sectional thickness of the mandible, not necessarily the height. So that's something that there's no real point. The original studies from Brunner-Mark were with interforaminal implants, and so there's no real need to go anything posterior past the mental foramen. What about implant tilting? Well, we can tilt implants. We've been doing them for a very long period of time. So there's no issue with tilting implants. So my standard protocol for the mandible, for instance, is 4 implants interforaminally. I tend to tilt the posterior implants to reduce the cantilevers. I prefer to use multi-unit abutments, straight multi-unit abutments rather than angled abutments. They have less issues with screw loosening and they're more robust. And always immediately load with a rod reinforced acrylic bridge so that I know that I've got good stability and good cross-arch stabilisation. So in the mandible, we have a very standard protocol of 4 implants placed interforaminally regardless of what goes on in the maxilla. And immediate loading we've been doing since 91, and where routinely we place 4 implants interforaminally since 94. So there's been a long period of time of immediate loading. Now, immediate loading and placement of implants is also something that has got a reasonable level of evidence, and it's a routine procedure in my practice. And so we can see here placement of removal of teeth, levelling of bone. The levelling of bone is incredibly important to create prosthetic space If you don't level enough bone, you get a very thin prosthesis that's then prone to fracture. You've also got the transition area between the tissue and the prosthesis is higher, so that affects the speech a lot more. It's more uncomfortable for the patient, whereas if it's deeper down into the sulcus, it's a lot easier for the patient to get used to. And so I can't stress enough that you need to have good, ridge reduction to create the space for the prosthesis. And so we place multi-unit abutments and closed tray impression copings for the jaw relations, and then we'll splint the implants together for a high quality type of impression, which we use just putty for, and then we'll make up the prosthesis and place that the following day. It's important to splint the implants together so that we've got as passive a fit of the temporary bridge as possible. You will also notice we place wide healing caps as well, and that keeps the tissue down so that the prosthetic phases are a lot easier. So once we've got that information, we've got an impression, we've got our jaw relations, we can then transfer that to the articulator and we can create a prosthesis. We like to have a 3mm rod, titanium rod that is laser welded to some titanium cylinders, and that gives us a very rigid prosthesis that is also less prone to fracture of the cantilever. It's more rigid, so you get less flexion of the acrylic, so you get less problems with teeth popping off or fracturing as well. We use high strength injection moulded acrylic, and the prosthesis is smooth and polished. And so we can go from this to this very easily. If we're looking at conversion to the definitive prosthesis, so generally speaking I'll have the provisional prosthesis in there for around about 6 months. Admittedly, with a rod reinforced prosthesis they can last for a very long period of time. I've got some that are over 10 years old, and for various financial reasons they may not go to the final prosthesis. But when we do decide to go to the final prosthesis, I like to have a Procera titanium CAD-CAM framework with good quality denture teeth, and that prosthesis supports all of the teeth. So going from appointment to appointment, appointment 1 we'll do another impression, so a final splintered impression, which we can also use to cross-reference with the original one. And we'll cross-mount using the provisional bridge. So we'll go, here we have the open tray impression copings. We have a wire that's placed passively, and then we'll lute that together with some light cured composite resin. This happens to be Triad by Dentsply, and which is very easy to use. You can of course use pattern resin. I find this a lot quicker. And we take another impression, a bite registration of the existing bridge. That impression, we have a soft tissue moulage and then a cast made. And then we use the existing provisional bridge. We use that existing provisional bridge to mount against the upper denture, upper teeth, whatever that happens to be. And so we've got a good starting point. If we were to raise the vertical dimension, we can use that with this. We can do whatever we want from that, but at least it provides a good baseline for the technician to do their work. Then at appointment 2, we try in a wax up of teeth and we do a verification index. This verification index, I can't stress enough. So what that is just some blocks of acrylic. They're placed in the mouth, and then they're luted together. Whether that's pattern resin or whether it's a Triad, doesn't really matter too much, but it needs to be fairly rigid. That can then be tried back on the cast that you poured from the first impression, and we can do the 1 screw test, where we screw down the posterior tooth, posterior implant, and if we get any movement around the rest of the arch, then we know that we've got an ill-fitting cast or ill-fitting impression. Either way, we know something's wrong. So then we can take another impression until we get it absolutely correct. At the same appointment, we'll also try in some teeth in wax, with an acrylic framework to see how the aesthetics, phonetics, occlusion, everything else. Then at appointment 3, we'll do a try-in of a framework. That try-in of the framework is a titanium made from Procera, and you've got various Procera framework designs from this type of thing. The problem is if you just have a straight bar like this, then the acrylic's got really nothing to adhere to, nothing to support it in lateral movements, and you tend to get these types of acrylic fractures. So I generally like to have some support for the individual teeth and sufficient bulk of acrylic so that we've got strength within the framework. So we'll use a double scan technique where the technician makes up an epoxy resin, and then that's scanned as well as the implants, the implant replicas, and then we can make something from that. And so this is the type of framework that we can get back. And so then we go to a try-in of the framework and the teeth. So we can just have a final check on occlusion, cleansability, aesthetics, phonetics, all those types of things. We can check and verify to make sure that the patient is getting exactly what they want. Then that goes back to the technician, he opaques it and creates the bridge. And again, we can check that, we can verify that that framework is passively fitting. And then at appointment 4, it's just a simple insert of the bridge. And we can see here the final result there and the radiographic evidence of that. It's important to go through home care, patient aids. We've had good success using oxyjets and water picks. That's transformed a lot of patients' oral hygiene. Obviously toothbrushes, things like Pixters, interproximal brushes, Superfloss, various bent single tufted toothbrushes, they can all be good. It's not to say that every patient uses all of them. It's more of a case of deciding, trialling out various things with that particular patient and working out what works best for them. We try to have a lot of the time a complete denture opposing a fixed prosthesis. That has less problems, as I said before. Certainly we do plenty of maxillary treatments, but if a patient is already edentulous, then this usually works pretty well for them. Most people cope very well with a complete upper denture if it's got good support and good retention. We try and minimise the cantilevers and the occlusal table wherever we can. Always have a retrievable screw-retained prosthesis. That allows easy maintenance. So if they fracture off a tooth or they break something or a screw comes loose, something like that, it's very easy to fix rather than a cemented one where you're basically stuck. Complete dentures are able to provide very good aesthetics and very good lip support. 4 implants, well spaced, allows good plaque control. You can use various types of home care, and the passive fit of a CAD/CAM framework like Procera reduces the component stress on the implants and on the prosthetic screws, and so you have a whole lot less problems than when we had, say, cast frameworks. And then the recall visits, as far as how often do we see people, they're tailored to the need of that particular patient. What we need to remember is they're on their 3rd dentition. They've already gone through 2 sets of dentition, so they need to be educated. So you need to have a hygienist that is particularly vigilant and likes to whip the patients into submission, but they need to make sure that the patients are doing the right thing because they don't have a good history to start off with. I'd like to introduce you to one other thing now that is called trefoil. So I'm involved with a multi-centre study. This is a concept that has been really developed by Kenji Higuchi, and I'd like to thank him for involving me in this particular study. What that means is that it's a 3 implant fixed restoration in the mandible, and the 3 implants are placed in a very precise manner with guided surgery, and then any misfit or misalignment of the implants is compensated for by a very sophisticated mechanism for compensating for any slight misfits of the implants. And that allows you to have a prefabricated, standardised framework that fits passively. And that's so that we're able to provide a definitive bridge at the time or very close to the time of surgery. So if we look at a patient here, this is John. He's a dentulous. He's been a dentulous for 12 months or so. We can go through some fairly normal diagnostic types of treatment, nothing too sophisticated here. There is going to be some level of bone levelling and placement of these 3 implants. These 3 implants are 5 millimetres in diameter and they have a 4.5 millimetre machine collar. They're placed in a controlled manner so that the 3 implants are a certain distance from one another and they're absolutely parallel. Then we go through some surgical prosthetic phases where we do a type of impression which is very quick and some jaw relations at the time of surgery, and then that allows us to go to the laboratory and create a hybrid prosthesis with a wraparound type of acrylic prosthesis over that titanium bar that fits very passively on those implants. And then we can deliver that prosthesis that day or the following day. And that's been highly successful so far. We're in the early phases, it hasn't been released yet, so I would say watch this space. This is a treatment modality that is probably going to be around about half the price of the current types of fixed treatment modalities for the mandible. So it's an exciting time. So I'd like to thank you very much for your attention at this lecture, and if you'd like to contact me or any questions, feel free. Thank you.